Hi everyone, this is Dr. Nakvi, consultant in general medicine. Today's video is very important as it will give you the basic knowledge of ECG. It does not matter that if you are an intern, medical student, house officer, or a resident. I will start from the basics. The initial portion of this video will be for interns and medical students, and then we will move on to further into more complex cases or more complex explanations. So we will start with the very basics of the ECG. Whenever you see an ECG, you need to know the few basic things. As you know that the basic, I'm not going into the details of this P, Q, R, S complex and T wave. You already know about these things. So in a normal ECG, this is the wave pattern. It may vary from lead to lead. For example, it will be a little different in chest leads. It could have a variation in limb leads as well. So whenever an ECG comes in front of you, you need to see few basic things. First, check out in the lower corner or the upper right or left corner that the speed of ECG, the basic on which the ECG is being done, it should be 25 by 10. So whenever a ECG comes in front of you, always look for these markings in the upper left corner or lower right corner. This is basically the recording speed of an ECG. If it will be like 25 by 5 or for example 20 by 10, the wave pattern will be different in that ECG. We can't really apply the criteria of different information like for the hypertrophy and these things over that ECG. So all the criteria that we will be applying, they are only applicable if your ECG is recorded on the speed of 25 by 10. Fine. Once you are sure about the speed, move on to the further. Now, if I'll zoom in this ECG, just look at these small squares. If I'll draw this one, this is a small square, the smallest one. So they elongate in the x-axis and on the y-axis. The smallest square on an ECG on its x-axis is 0.04 seconds. You need to cram it. You need to remember it by heart. So if I join 5 of these small squares on x-axis like this, the total time for these 5 small squares become 0.2 seconds. Let me show it on ECG. Okay, let me show it on ECG. If I'll consider these 5 small squares, they total become 0.2 seconds. So if I calculate 1, 2, 3, 4, and 5, these 5 small squares, they are equivalent to 1 second. Why is it important to understand the length of time over these small squares? Because in later on, when we will be calculating the heart rate in abnormal rhythm, these timings, these small squares are going to help us. Similarly, if we move along the vertical axis and we will start stacking up the small squares in a vertical fashion, One smallest square is equal to 0.1 millivolt or 1 mm. Why is it important to label the voltage or in the vertical axis? Because when we will be talking about the hypertrophy in the vertical axis, we will be calculating these boxes. Now we are done with the ECG paper speed. I have told you about the small square pattern. Now moving on further, we have some segments in ECG and there are some intervals. I want you to remember there are two segments. They are clinically very important. One is PR segment. Just remember it by heart. What is PR segment? PR segment is it starts at the end of P wave and it ends at the start of Q wave. That is your PR segment. Okay, and that is very important. Just remember it by heart because it's clinically important. And if I'll talk about the other segment that is very famous and everyone knows about it, this is ST segment. You already know what is ST segment. ST segment is basically a segment at the end. If I'll draw this QRS complex, it is ST segment is at the end of S wave and at the start of T wave. This is your ST segment, and it is super important to remember because it is the single most clinical criteria for the clinical diagnosis of myocardial infarction. Let's jump towards the intervals. There are five intervals, they are very important. First one is PR interval. PR interval, due to its clinical significance, that I will talk about it later if I'll consider it clinically important for junior level. Basically, PR interval is at the start of P wave. From here, the PR interval, we can say that from here to here, this is PR interval. So it becomes shortened in certain type of clinical diseases. If I'll talk about the another interval, that is QRS interval, it is also very important to understand the basics of QRS interval. QRS, if I'll draw the ECG pattern, this is P wave, QRS, and T wave. This is your QRS interval. Why QRS interval is important? Because there are certain type of tachycardias, wide complex or narrow complex tachycardia. We will classify these tachycardias depending upon the interval of QRS. Now the third one is QT interval. Now the what is QT interval? QT interval, it starts from the start of Q wave. If I'll draw the pattern, this one Q and this one T. QT interval starts from the start of Q wave and it goes all the way to the end of the T wave. This is QT interval. QT interval is clinically also very important because there are certain types of drugs that prolong it and it has got some clinical implication as well. The fourth one is, and very close to it, is ST interval. You remember ST segment? It includes ST segment plus T wave. This ST interval, let me show it to you on this ECG. Say, for example, this is P wave, QRS, and this is T wave. So, what will be the ST interval from here to here? This will be our ST interval. Now, the fifth one, which is also very important, is RR interval. Now, RR interval, we do certain type of calculations from RR interval. In later on in this lecture, you will see we'll be calculating certain things from the RR interval. Now, let me show it to you on this by making a rough ECG pattern. This is P wave, QRS, T wave, then there is another, for example, P wave, QRS, T wave. So this interval from one R to the another R, this is your RR interval, and it is also important. As far as their normal values are concerned, just open any website, open any book, you can download any picture of that, and I will definitely post these in the description as well. Just remember those by heart. Now, what about the leads, ECG leads? We have two kinds of ECG leads. Not two kinds, basically, we can divide them, these ECG leads, into two groups. One group is limb leads, and are precordial. We all know that precordial leads are denoted by V1 all the way to V6, and limb leads 1, 2, 3, AVR, AVL, and AVF. Now, the next thing is that I'm going to draw a diagram, a rough diagram about the lead placements of these ECG leads. You know that this precordial leads, if I'll draw a sternum like this and they are placed like this, these are the precordial leads. As far as the limb leads are concerned, this one is my favorite diagram for the limb leads. If you draw a Y, this is your AVL, this is your AVR, this is your AVF. Now, the axis of the normal axis of these are the normal axis of limb leads. This is your lead 1. Lead 2 kind of goes towards like this area, and lead 3 here. Now, these are all the positive axes of these leads. Remember that we are going to calculate the axis from those two leads which are right angle to each other. Actually, we can calculate the axis from any of the leads, but the complication, their calculation becomes pretty much complicated. So we prefer to take those limb leads which are right angle to each other. These are their normal axes. If they will go towards the other side, their axis will become negative. For example, lead 1, and this I will just give you a reference of lead 1 and AVF. Okay, just remember it as for now. Just remember this diagram. Your AVR is on the, consider a person lying down. This is the head side and this is the limb side. This is the limb side of the patient. This is the head side, and you're watching the person from the foot end on, and the person is laying down in upright position. On the right of his arm, there will be AVR, then there will be AVL. Lead 1, AVF will be just in front of you over the foot side, and lead 2 or 3 that I have shown you in the figure. I would also like you to remember few things. There are certain types of phases of ECG. I mean, these ECG phase to a specific side of the heart. For example, uh, lateral sides, if a person is having lateral wall MI, the changes will be lateral wall MI, the changes will be prominent in lateral leads. Which are the lateral leads? It will be prominent in lead 1. They may come in lead AVL if it is higher. There is a subcategory of MI. Changes will be evident in these area lead 1 AVL. They might come in V5 and V6 as because they are also kind of facing the lateral side of the lead. If a person is having inferior wall MI, these leads will be facing the inferior side of the heart. The changes will be evident in these leads. And then remember precordial lead, they are placed over the chest. If there is anterior wall MI, the interior side of the heart is being faced by V2, V3, V4. These anterior basically these leads face anteroseptal area. So the changes will be evident in V2, V3, V4 in anteroseptal MI. So this concludes our basics of ECG. Now this portion is for students and you can say interns. These few points will be very important for them and they will be asked in exams as well. So in OSPs, OSCEs, usually a teacher expects you to tell them if any of these things are not good in ECG. So let's just start with the first thing. First thing, I'm going to talk about the rhythm. How do you check the rhythm of the ECG? There is a very crude method, a perfect method, and very good method to check if the rhythm in the ECG is normal or not. Take a piece of paper, put this paper over the ECG. For example, if I will roughly draw, let's go towards the top over the ECG paper. Take a piece of ECG, I mean, to take a piece of any paper, put it over, for example, this is your paper. Put it over the ECG paper. Now mark 3 consecutive QRS complexes over this paper. For example, put a dot over here, put a dot over here, and then put a dot over here. Now the next thing you need to do is move that paper one by one on the next QRS complexes. Just if you will move this QRS this paper to the next QRS complex, so it will be like, let me clear it off so that, so if you will move this paper on which you have marked, for example, you move towards this side and you draw it over here, The dots you have placed over the paper will exactly, if they exactly fall over the next consecutive QRS complexes, then the rhythm is normal. Now, for example, if the rhythm would have been abnormal, your one dot might be, let me try it again so that you won't forget it. So if the rhythm would have been abnormal, so for example, you have placed previously three dot consecutively, there is a chance that your one dot will lie over here, your next dot might lie over here, and your next dot might lie over here. Now look at this QRS complex. These consecutive three QRS complexes does not correspond to these dots. If they directly do not coincide with these dots, then there is a problem in the rhythm. The rhythm of the patient, the rhythm of the ECG is not normal. Okay, this paper method is super easy, and it will show you that the rhythm of the ECG is normal or it's abnormal. Now, how do you calculate the rate of the ECG? Rate means heart rate. How would you calculate? There are certain ECGs in which the heart rate is mentioned at the top. However, if it will come in exam, it will not be definitely there. You need to calculate it by yourself. Now, I want you to remember this sequence of numericals: 300, 150, 100, 75, 60, and 50. It is very easy to remember. Just remember this sequence by heart. Now, if you remember, I told you was a small square, then a combination of small square, five, it, it become a little big square. Then there was another five square. They move towards the x-axis and make a pattern like this. I won't be drawing it any further. Now place all these numericals over here. 300, 150, 100, 75, 60, and then 50. Let's suppose we take this QRS complex that is coinciding with the start of the small squares. Now what you have to do is, if I will show you the pattern of 300, that numerical that you have just remembered by heart, this one, this one, then this one, then this one. Apply this over that counting over this one. From here, it's the reference point. This is 300. This is 150. This is 100, and so on. Okay. So we have taken this QRS complex as our reference point. Now see where is another QRS complex coinciding with any of small square box or any uh, line over there, any dark line over here. This is our 300 milestone. This is our 150 milestone. This is our 100 milestone. This is 75 milestone. And this one is 60 milestone. If this QRS complex would have been over here, then heart rate would have been 300. If this QRS complex would have been over here, the heart rate would have been 150. If this QRS complex would have been over here, then it would have been 100. This one is 75. Now this QRS complex lies between milestone of 75 and 60. So this is 75 and 60. If you calculate there are how many small squares between these milestones, these are 5 small squares. And the heart rate from here, this is 75 milestone and this is 60. There are total 15 heartbeats from 60 number to 75. 15 heartbeats. If so, how many heartbeats can be divided upon each small square? That will be divided by 5, 3. With the simple mathematics, you know that now that from here to here, 75 to 60 milestone, in between there are smallest squares, and each square is 3 heartbeats, and each square holds 3 heartbeats in it. So this QRS, the apex of this QRS complex is on the second smallest square. So from this is 75, this is 60, it is going towards the decrease. If you eliminate, so this small square, these 3 heartbeats, it becomes 72, and it is on the second smallest square. You minus 3 more, so it becomes 69. So your heart rate becomes 69. Now, for example, now if I will take a reference point, that this as a reference point, and your next QRS complex is lying between over exactly over this line. Another method is, what you can do is take these two small, not the smallest square, but the small squares. Count these small squares that are coming between two QRS complexes. For example, from this complex to this complex, there are two small squares. Not the smallest squares, but small squares. This is 1, this is 2. I'm not talking, please remember that I'm not talking about these smallest squares. I'm talking about small squares. So there are two small squares. Roughly, you can divide 300 by 2 and your heart rate becomes 150. You can do this as a rough calculation of heart rate. But what if this is your reference QRS complex and your next QRS complex lies in between two milestones? Now, apply the method that I have previously told you. For example, it is lying over this area. Now, calculate the smallest squares between 150 and 100 milestone. These are the 5. And how many heartbeats are there between 150 to 100? These are 50 heartbeats. So each small square will be holding 10 beats. If I'll calculate from here, this one, 1, 2, 3, 30 heartbeats are before these dotted lines. So you can minus 150 minus 30, it becomes 120. So your heart rate becomes 120 over here. I hope it's pretty much clear to you. If it is not clear, you can watch it again. Somehow you will get a grasp of it. We apply this method only for those ECGs which have regular rhythm. If the rhythm is regular, then we can apply this method. If the rhythm is irregular, how can we calculate the heart rate? It's very simple. It's very simple. Remember, I told you initially the smallest square is 0.04 seconds, and for five smallest squares become one small square, that is zero point 0.2 seconds. Similarly, five of these small squares, they will be equivalent to 1 second. Now we have two methods of calculating the heart rate in an ECG which is having irregular rhythm. Take a 6-second rhythm strip and calculate the total QRS complexes in that 6-second strip. For example, the total QRS complexes in that 6-second strip are, for example, 5. If the rhythm strip is 6 second, then the total QRS complexes should be multiplied by 10. That will be your heart rate. There is another method. You can take 10-second. In extreme cases of bradycardia, sometimes you have to take a very long rhythm strip. Take 10-second of rhythm strip. Calculate the total number of QRS complexes in that rhythm strip. Now, if it is 10, then the total QRS complexes, for example, it's 5. You have to multiply it with 6. Your heart rate will be 30. And this one is your heart rate. So if the rhythm is regular, apply this 300, 150, 175, 60, 50 method. And if the rhythm is irregular, take a 6-second strip or 10-second strip. If you take 6-second strip, multiply it with 10. If you take 10-second strip, multiply it with 6. What you should multiply it with? That is your QRS complexes, not the seconds of the strips, because it will answer the same. If you will multiply these, it will be 60. If you will multiply by these, multiply each other, it will be 60 always. But you have to multiply the always the QRS complexes with 6 in case of 10-second strip, and QRS should be multiplied by 10 in case of 6-second strip. So I hope it is very clear to you. Now, third thing, for house officers and med students or interns, is access. Many people would have told you the rule of thumb, and there are many tweaks, but let me give you a very simple and easy way to remember, to see if it is left axis deviation or right axis deviation. Do you remember that diagram I have told you? That why ECG placement diagram, this one. Initially, I have told you this one. Just remember this diagram, I hope. This was AVR, AVL, lead 1, lead 2, AVF, and lead 3. And we can calculate the axis from any of these leads, but remember that it will be very easy for you to calculate the axis if you take any of these two leads which are at the right angle to each other. They are 90 at the angle of 90 with each other. It will be the calculation will be super easy. How about we take these two leads, AV1 and AVF. I will draw them separately now. This is lead 1 and this is AVF. You all remember that normal axis of the heart. If I'll draw the heart, please forgive me for my bad drawing. Let's say it is the heart. It is more like a pear, less like a heart. But still, let's for example, this is the heart. The axis of the heart, it's between lead 1 and AVF, right? This is the normal axis of the heart. In the normal heart, the current will always flow in this direction. Let me draw this axis again. This is your normal axis of the heart. This is your lead 1. This is AVF. The current, flow of current, all the positive deflections in lead 1 and AVF with the normal axis, they will be in positive direction. If I'll draw the QRS complexes in lead 1, QRS complex will be like this, and AVF will also QRS complex will be like this. The current is flowing towards the leads, so on ECG there will be a positive deflection. If I will draw their negative vectors of current, in just the positive of lead 1 it will be negative, and if I will draw the AVF in the opposite direction, AVF will be negative over here. Now if you remember the basics of mathematics, you would have seen that you must have drawn the graphs in your 9th or 10th standard. You remember positive axis and negative axis. This is lead 1 with positive axis, lead 1 with negative axis. AVF positive, AVF negative. This is your left axis deviation region. This is your right axis deviation region. And we can say this the extreme right axis deviation, extreme right. There are certain cases in which it becomes important. We will not talk about those conditions over here. Now, usually, normally, the current is flowing between the positive terminal, positive towards the positive sides of lead 1 and AVF. So, in a normal ECG with a normal pattern of the axis, your both lead 1 and AVF, the QRS complex will be positive in them. Okay, there will be huge positive deflection. They both will be positive. This is normal. Now, what if the patient is having left axis deviation. This is the region of left axis deviation. Let me draw it again for you. In left axis deviation, if I'll draw the leads again, lead 1, AVF, I have told you that this region is your left axis deviation. If you recall your basics of mathematics, lead 1 is positive over here. This is the center of origin. In this area, which lead is positive, which lead is negative? This is the center of origin. AVF, if it will lie to the other side of origin, it will become negative. Okay. And lead 1, if it will lie on the opposite side of the origin from the positive side, it will become negative. So in left axis deviation region, your lead 1 is positive. This area of lead 1 is positive. Okay. This area of lead 1 is negative starting from this. So your lead 1 is positive. Look, and let me draw it again for AVF. This area of AVF is positive. However, this area of lead 1, lead AVF is negative. What happens in left axis deviation? This is your lead. Your lead 1 is positive. You will see a positive QRS complex in lead 1 and AVF. AVF is on the opposite side of origin. It becomes negative. This is your lead 1. In AVF, you will see the pattern like this. Okay, this your QRS complex, it become negative in lead AVF. Just imagine this is your negative side of AVF and this is the LAD region, left axis deviation. Your lead 1 is positive. If you will go through the ECG, in ECG, lead 1 will show a positive deflection in QRS complex, and in AVF lead, the QRS complex will be negative, and the patient will be having left axis deviation. It's that much simple. Now, what about right axis deviation? Just apply the same logic, the same basics that I have told you. This is lead 1, this is AVF, your this is normal axis. Now this one is negative lead 1 and this one is negative AVF. Your this is the region of right axis deviation. Your right axis deviation axis lies over this region. Here, which vector, which axis become negative? Look, this whole section, this whole section of AVF is positive. Fine. And this whole section of lead 1 is negative. Now, if your axis lie over this region, come towards the negative end of lead 1 and stay on the positive side of AVF. If you will look into the ECG, your lead 1 become negative and your AVF will stay positive like this. QRS complex is negative and in AVF QRS complex will be positive. So we can say this is your right axis deviation in which the lead 1 becomes negative, this one, and your AVF is positive over here. Your AVF stays positive. Now, what will happen? What about the extreme right axis deviation? What will happen if the axis lie over this region? You can see AVF, it is negative in this region. Lead 1 is also negative region. This is the negative region of the both leads. What you will see in ECG, lead 1 will be having negative deflection and AVF will also be having negative deflection. So they both will be having negative QRS complexes. That's how you can determine the axis in any ECG. The next most important thing is ST segment elevation and non-ST segment elevation. I'm not going to talk about the criteria of myocardial infarction because in both the precordial leads and the limb leads, it's a little different and it depends upon the gender, it depends upon the age of the patient, I mean the elevation of this segment or the depression of this segment is interpreted usually depending upon the age of the patient, gender of the patient, and depending upon the leads of the patient. All I'm going to tell you what is ST segment elevation and what is non-ST segment I mean what is ST segment depression. Let's just put it in the simple words. So we talked about previously ST segment. This is your ST segment. Sometimes it happens due to myocardial infarction. This is your P wave, QRS complex, and this is your T wave. There's in this region there start some changes. Now, what could be the changes? Either it gets elevated, it does not come towards the baseline before going towards the T wave, or it gets depressed. How does it look like on the ECG? It it will be like this. If it is ST segment elevation, this is T wave. Let's talk about T wave inversion a little later. But this is your ST segment. This is your baseline. It gets elevated. If you see this type of changes on the ECG, you are a student, you are a intern or a house officer, that is the time you run towards your senior because your patient is having an MI. So this is Q wave, this is R wave. It does not touch the baseline. It stays elevated from the baseline and it appears like this. Look, this is the elevation. How does the depression look like over the ECG? Straight away, if I'll draw Q wave, R wave, this is S wave, and it will be like this. It will be a baseline, and ST segment either it will have come down or it would have gotten up from the baseline. This is ST segment elevation or non elevation. I mean, ST segment depression. If you find these two findings over the ECG, that is the time you need to run towards your senior. Just move on to our next part, hypertrophy. We have two kinds of hypertrophies for the heart. One is left ventricle hypertrophy and right ventricular hypertrophy. They both are very easy to find on the ECG, very common to find over the ECG, and you can come across many of these ECG in which you will be able to easily diagnose a patient with any of these kind of condition. Let's just start with LVH. There are many criterias for LVH, left ventricular hypertrophy, but I'm going to tell you the simplest one, that one I love to follow the most. The one that I love most and easiest to remember is Sokolov-Leon criteria. Let me draw an ECG pattern in the precordial lead, and I will be drawing only QRS complexes. So if you move towards V1 to V6, your ECG pattern of QRS complex is like this. For example, I label it V1, V2, V3, V4. Sorry, it's V4, V5, and V6. You can uh, clearly see that there is a pattern of R wave progression towards the upper side, towards the more positive deflection. And with the passage of time, this R, if I'll draw this baseline from here, from baseline, this R wave, it start progressing towards upwards, upside, if we move from V1 to V6 in normal ECG. And this S wave, with the passage of time from moving from V1 to V6, it start disappearing. It's I mean uh, its length, it shortens, and as a matter of fact it sometimes disappear in V5 and V6. Now what is the criteria? Criteria says that if you take S wave of lead V1 and you add it to the R wave of either V5 or V6, if it is equal to or more than 35, sorry, the sign will be in the other way. If the sum is more than 35, millimeter, then it is left ventricular hypertrophy. How will you calculate this 35 millimeter? If you remember at the start, I told you that if we move towards the y-axis on the ECG paper, the smallest square is equal to 1 millimeter. So the S wave, this wave plus this wave, if they both are more than 35 millimeter, then it is your left ventricular hypertrophy. Let me show it let me show it to you on the real ECG paper. Look, here is V1. Look, can you see the progression of this R wave? V1, look at this. Look at this wave. R wave is small, and if it is go to, if it in lead 2, it's making a little progress. In lead 4, 5, 6, it's getting bigger and bigger. And this S wave is getting smaller and smaller. Now for LVH, what we are going to do is we calculate this distance. Now take it, roughly it is 10 millimeter. And look at the lead 6. It is around 10 and 13 millimeter. So 13 plus 10 is equal to 23 millimeter. This is not left ventricular hypertrophy. This is normal. You can Google it over the internet. You may find many of the websites and many of what you call it sites in which you can find the different examples of left ventricular hypertrophy ECGs. Go through that and you will never forget it. Now, what about right ventricular hypertrophy? Look at this ECG pattern. Normally, your R wave is getting bigger and bigger, and your S wave is getting smaller and smaller. Now, what happens in right ventricular hypertrophy if I will draw if I will draw the wave pattern of QRS complex in V1, the R wave will already be bigger than S wave in right ventricular hypertrophy. This is a single most important indication that patient is having right ventricular hypertrophy. If you just imagine this pattern, I'm going to copy this pattern. The ECG is normally going like this. R wave is going like this. This is isoelectric line. This is normal. However, in LVH, it went like this to my 35 criteria. And in right ventricular hypertrophy, look at this chart. In RVH, if I will draw, for example, this is isoelectric line. The QRS complex, the R wave will already be so much positive. The R wave will already be way bigger than S wave. And if you will trace the pattern of this QRS complex in the ECG pattern, it will be more like this. The biggest R wave you may find will be in V1. The pattern would have changed from normal this pattern towards in RVH towards this pattern. The point is in V1 you will always find the R wave bigger than S wave. It will be a single most important indication that patient might be having right ventricular hypertrophy. Now let's talk about the block. There are many types of blocks like first degree, second, third, then there is LBB, then there is RBB, then there is bi and trifascicular. However, here we will only talk about this first degree, second degree, third degree, and LBB and RBB. Now, first degree block. If I'll draw this P, QRS complex, and T wave. Remember, I told you there are few segments and few intervals. Do you remember that I told you something about PR interval? This is PR interval. What happens in first degree AV block? There is progress in any ECG, there is lengthening of this PR interval. How much increase in PR interval happens? It is more than 200 milliseconds. How do you calculate 200 milliseconds? I told you that the smallest square was equal to 0.04 seconds, and five of these smallest squares making a small square is equal to zero point 0.2 seconds or 200 milliseconds. If you will look at the ECG of this patient, you might find this is your small square, not the smallest, but the small square. I'm talking about this one. So, more than one small square can fit into this PR segment. It will be lengthened more than this one is 200 ms. Okay, and it is even wider than that. So if PR segment is more than 200 milliseconds or zero point 0.2 seconds, it is your first degree AV block. Now let's talk about second degree AV block. We have two types of second degree AV block. One is called type 1 and other one is called type 2. There is small difference over the ECG pattern of these two blocks. In type 1 Mobitz block, I mean type, type 1 second degree AV block, there is progressive lengthening of PR interval. For example, this is T wave. In the next one, this will be the P wave a little more. then T wave. In third one, then there is a P wave, a little more than that. The PR segment is has been lengthened a little more, then QRS complex, then T wave. Ultimately, then there is a P wave. If I'll continue it over here, for example, if I'll draw this P wave over here, this is P wave. There is no QRS complex or after it. Then there is another P wave, then QRS complex. So what happens here is there is progressive lengthening of PR interval. Look at this one, look at this one, then again this one, then this one, and ultimately a drop in QRS complex beat. So type 1, progressive lengthening of PR interval culminating into a drop of QRS complex. What happens in type 2? There is P wave, QRS complex, T wave, then there is P wave, QRS complex, T wave. There might be a P wave, then again a P wave, QRS complex. There is no progressive lengthening of this PR interval. However, the beat P wave, this P wave, there is a drop of QRS complexes independent of the lengthening of PR interval. In Mobitz type 1, there was a progressive lengthening of PR interval culminating into the drop of the QRS complex, drop of a beat. However, in type 2, the PR interval does not progressively become more and more, it stays the same, but there is an independent drop of QRS complex. There is no QRS complex after one beat, there is another P QRS complex, then T wave. The QRS complex gets eliminated independent of lengthening of PR interval. So I highly recommend you to see the ECG, scroll down, go to the Google, search over it, type 1 and type 2 Mobitz heart block, and you will see many of the examples, and that's how you will remember it. Now, what is third degree AV block? So, what happens in third degree AV block? There is P wave, QRS complex. This P wave become they have independent tracing over ECG, and Q wave have their own independent tracing over ECG. P wave is strictly not followed by QRS complex. Sometimes there is P wave, then there might be another P wave. Soon after that, there is QRS complex. Soon after, there is P wave, QRS complex. In short, QRS complex is from the beating of ventricles, and P wave is from the atria. Atria is sending their own impulses in the form of P wave that are recorded over ECG paper independently, irrespective of any correlation between P and QRS complex. Normally, you see that there is a P wave, soon after that, there is a QRS complex, then there is T wave. So, this is P wave, QRS complex, T wave. So, what happens in third degree AV block? P, you will find numerous P waves, but it is not always the case that this P wave will be followed by QRS complex. QRS complex will these QRS complexes will have their own ECG tracing, and P waves are will be distributed among these QRS complexes independently. Now let's talk about very important point, that is right bundle branch block. I will not go into the causes and other details of these bundle branch block. Right bundle branch block, just remember two things in the just see the two things in the ECG. If QRS interval, remember we talked about the interval. Normally QRS complex is less than 0.12 seconds. These are three smallest squares. A QRS complex should fit in these three smallest square. If it gets widened, if I'll draw corresponding to these three these three smallest squares, if I'll draw a QRS complex, if it become like this, it has been widened. If it is more than three small squares, it is more than 0.12 seconds. So first thing is, look into the ECG that your QRS complex is having normal interval or it is more than 0.12 seconds. If it is wide, now look at the lead in V1. Look at the wave patterns in lead 1. If there is dominant R wave in V1, it will be the right bundle branch block. So right bundle branch block is dominant R wave in V1 with QRS interval more than 0.12 seconds. If I'll hand you over an ECG and you see there is a wide QRS complex more than 0.12 seconds, straight away jump towards V1. If you find dominant R wave in that lead, then this is right bundle branch block. Now, if you remember a mnemonic, Marrow and Williams, you might have come across in many ECG books. Basically, we are talking about right bundle branch block, so you will find M pattern in lead V1 and W pattern in V6. Uh, Strictly speaking, maybe, just maybe, I have not observed this marrow pattern in these right bundle branch blocks ECGs that much. So I usually go with that pattern. If there is dominant R wave, I mean R SR pattern in V1 and QRS complex is widened by more than 0.12 seconds, I label it as a case of right bundle branch block. However, you may find the pattern of this, basically RSR pattern will be like this. This is small r, this is S wave, and this is RS wave. And if you see it in marrow mnemonic, this becomes kind of M. Same way, reverse, you can find it in lead V6. Just make it simple. First, CQRS complex, if it is more than 0.12 seconds, straight away jump towards the lead V1. If there is RSR pattern or dominant R wave, then it is right bundle branch block. On the contrary, left bundle branch block, if there is if you find QRS complex wide more than 0.12 seconds, and you find dominant S wave. For example, in lead V1, dominant S wave in V1, the S wave will be like this. QRS complex will be wide, and this will be S wave. It will be more than R wave. It will be dominant wave. Then this is left bundle branch block. Bifascicular and trifascicular, it's a little bit complicated and you won't understand without the example ECGs. So I suggest you that you skip it for now. Let's move on to another very important topic, arrhythmias. There are many classifications of arrhythmias, but I will be not going into the details of classification because of tachyarrhythmias, bradyarrhythmias, then narrow complex tachyarrhythmias, wide complex, and there is a huge mess in that, and you will definitely get puzzled by hearing about it. Let's just keep it simple. Very common presentation I'm going to talk about atrial fibrillation. What happens in atrial fibrillation? Patient will be an elderly patient, probably a smoker having some kind of respiratory illness. And if you will see the ECG pattern, there will be no P wave. QRS complexes will be distributed sometime towards small. I mean, there will be no normal rhythm between QRS complexes like this. There will be no P wave. I deliberately did not draw here the T wave, but sometimes you may find a little electrical abnormality over the baseline, and sometimes you do not even find the baselines. All you see some vibrations, like the pattern will be like this, but there will be no clear cut P wave. P wave will be absent. And if you will place a piece of paper and mark these QRS complexes, and you will move it to the adjacent QRS complexes, they will not fall on the adjacent QRS complex notch. They will be like this at the different region. So what happens? Rhythm is irregular and plus no P wave. That makes it atrial fibrillation. Now, atrial fibrillation is very common in elderly patients, sometimes cardiac patients, sometimes the patients who are having respiratory illness, for example, COPD. Let's not go into the details. All you need to do is whenever an ECG comes in front of you and the age of the patient will be mentioned over the ECG. If the rhythm is not regular and there is no P wave, then there is a high chance that this might be a case of atrial fibrillation. There is another condition, supraventricular tachycardia. This is a term. Sometimes it's my personal opinion that it's a misnomer. Any any tachyarrhythmia, tachycardia, any kind of tachycardia originating above the ventricular is basically a supraventricular tachycardia. However, This supraventricular tachycardia SVT is mostly labeled uh, to those ECGs in which there is narrow complex QRS tachycardia. All the QRS complexes having normal rhythm, but the patient's heart rate is very, very high and there is no discernible P wave. You can't see the P wave, but the QRS complex rhythm is similar. Look at the atrial fibrillation. There was a difference between the length of RR interval. If the RR interval is same for all the ECGs, I mean all the wave patterns, and there is no P wave, RR interval is same. Sorry, RR interval is same, no P wave discernible, and patient is having high heart rate and tachycardia, you can call it tachycardia, then there is a very high chance that patient is having SVT. Just see the examples over the internet. Search in the Google ECG of SVT. You will see many cases. Just look at the P wave. There will be no discernible P wave. RR interval will be the same and the heart rate will be very high. Now, there is a very close condition uh, to that this tachyarrhythmias, that is atrial flutter. Now, atrial flutter is a kind of ECG. When it comes in front of you, you cannot miss it. If I will roughly draw a pattern of atrial flutter, this is QRS complex. This is sawtooth appearance, then again QRS complex, sawtooth appearance, QRS complex. This sawtooth appearance, it is basically the flutter, atrial flutter. The heart rate will be very, very high, around, possibility is it could be around 200, and there will be visible, a very discernible P waves, but in the sawtooth pattern, sawtooth pattern like this. Sometimes it could be 2, 3, 4, and sometimes it can be noted like 8, up to 8 sawtooth appearance in the flutter. There are many types of flutter, 2:1 and 3, 4. I will not go into the details. If you see a patient having tachycardia and there is a sawtooth appearance like this over the ECG in between QRS complex, sorry, if I'll draw it again, in between QRS complex, there is a sawtooth appearance, then this is atrial flutter. This is a simple and easy thing to remember. You won't miss it if you will see it for once in your life. Now, that brings me to the next and one of the deadliest arrhythmias, V-Tach, ventricular tachycardia. Ventricular tachycardia, there is a different type of classification for ventricular tachycardia. Basically, it comes under the heading of wide complex tachycardias. There is monomorphic ventricular tachycardia and there is polymorphic ventricular tachycardia. However, I am only going to talk about V-Tach over here. If you see a pattern like this is the roughly sawtooth, but it you will only see the sawtooths in this type of pattern, or the QRS complex will lose its proper shape. Usually the QRS complex is like this. It becomes like this. When you see the ECG pattern like this, you do not say anything to anyone. You run towards your senior, because that is potentially a killer, uh, a killer presentation that can easily kill a patient in no time. However, there are some what you can say clinical implications also there. If there is pulseless V-Tach, what we have to do about it? If there is pulse, we have to stay calm, and then we call the senior and they will revert it. However, look, the ECG pattern you will find in ventricular tachycardia will be like this. It could be like this. There will be no proper QRS complex, and P wave is out of question in that. Just search on internet, search in Google, uh, ECG pattern, ECG of ventricular tachycardia. You will find it, or you will find it a lot more examples over the internet. To recapitulate once again about ventricular tachycardia, QRS complexes will be wider, more than 0.12 seconds. There will be no definite P waves. P wave is out of question. You won't find it P wave in QRS complexes, and they will be regular in one lead. However, there could be a variation. Sometimes the capture beats or fusion beats, they can portray in between these complexes like an abnormal bizarre complex. However, most of the time the pattern will stay same like this sawtooth, but the bigger sawtooth and more wider. So moving on towards the ventricular fibrillation. Usually ventricular fibrillation is pulseless, and you will find a little haphazard pattern. The QRS complexes are will be varying in amplitude, will be varying in rhythm, sometime a small like this. This is fibrillation. We are basically the QRS complexes will be bizarre. There will be no specific pattern. There will be no typical sawtooth, but that variable saw you can say it will be a variable sawtooth appearance. Mm, QRS complexes will be varying, sometimes small, sometimes big, sometimes smaller amplitude, bigger, I mean, more strong amplitude, more wider amplitude. There is no definitive pattern. The clinical correlation to ventricular fibrillation is that the patient will not be conscious, he will be pulseless, and this is the most critical cardiac emergencies in arrhythmias that you can find. There is another type of polymorphic. Polymorphic VT, I thought that is a bonus point that I can tell you over here. You would have heard about torsade de pointes. Torsade de pointes, in which the ECG pattern becomes like this. The QRS complexes become wider, I mean, more in amplitude, then they become small, then become more in amplitude, more and more, and then they become small. So this is torsade de pointes pattern. of one of the types of ventricular tachycardia called polymorphic VT. So that was all about the basics of ECG for interns and house officers. There's one bonus point I would really like to remember you all. This is the ECG I got in one of my exams. So when I saw the ECG, let's talk about one of the point. Let me give you one point over here. I told you about a lead AVR. That lead is always, always negative. Always negative. I deliberately skipped that point in the basics of ECG because I wanted to tell you over here. It is very much related to what I'm going to tell you next. So, when an ECG comes in front of you, you check the speed, it's 25 by 10. Then, the next thing you should look is its AVR. AVR in normal ECG, it should always be negative. Negative AVR means all the ECG will be a mirror pattern of other ECGs. P wave will be negative, then there will be QRS complex. So the P wave will be negative, QRS complex, then there will be T wave. If you roll it upside down, if I will draw the normal P wave, QRS complex, T wave. Just look at this one. If you flip it upside down like this, it will become upside down flip pattern, mirror pattern of this ECG. Now, what I'm going to tell you, it's a bonus point and it is the most beautiful point of the ECG. Just remember that you will always find P, negative P wave, negative T wave in this negative wave pattern in AVR. But if somehow you find this pattern in AVR, positive wave pattern, then there could only be two possibilities. And these possibilities are very important that will tell the other person that you really know about the ECG. One possibility is that the person is having dextrocardia. His heart is on the other side, I mean, towards the right side of the chest. So that's why the vector, the flow of current is going towards the opposite direction. Other thing is, and that is most commonly practiced, sometimes it happens with our paramedic staff that they have placed the ECG leads wrong pattern in a very wrong pattern. So there are only two possibilities of having positive AVR. One is dextrocardia, other one is wrong placement of ECG leads. So how would you differentiate if the person is having dextrocardia or the ECG leads have been placed in a wrong fashion? Look, in dextrocardia, let's talk about dextrocardia first. If AVR is positive, straight away jump towards the precordial leads. In precordial leads, V1 to V6, I told you there is normal isoelectric line and there is a progression of R wave. If if a patient is having dextrocardia, this R wave progression will be lost. There will, because the axis have been changed towards the opposite side, the ray current will not flow towards the normal axis of the heart. So this progression of getting higher amplitudes from V1 to V6 in R wave, this pattern, it will not be there. Progression of, in short, the progression of R wave will not be there. This will not be there. And on the other hand, if there is wrong placement of ECG, wrong placement of ECG leads, then what happened? AVR will be positive, and from V1 to V6, the progression of R wave, it will be normal. Look, this is only two differentials and common differential, not that much common, but the common differential that you can ever come across in your exam. If the AVR is positive, there can be two differential: either the person is having dextrocardia, or the leads are accidentally placed on the wrong arm. To differentiate in between these two, just look at the pattern of V1 to V6. If the R wave, the progression of R wave is lost, then your patient is having dextrocardia. However, if there is a normal progression of R wave, then the ECG's leads are wrong. They have been placed accidentally wrong. So this is the end of our ECG lecture. Yes, I deliberately did not put the real examples of the ECG due to copyright issues. Remember me in your prayers. Please do like, comment, and subscribe.